Okay. Right, okay, so welcome to this week's webinar. I'll get straight to it because I don't want to impinge on the time we've got. I've got a few late notes here. It's not going to be as detailed as Justin's update because he's having some well-deserved rest this week. So beginning then with the case rates, if you'll have seen this week's email, you'll be glad to have noticed that all the rates have dropped mostly across the city, apart from a few exceptions. Obviously, this doesn't mean that we're out of the woods yet, but it's an encouraging sign to go in tandem with the increased number of people getting tested, obviously taking the vaccine as well. And yeah, like I say, you can find all this detail on the dashboard link, which was in Tuesday's email update. After that, a latecomer to this, to the news this week. So as well as the BAME community webinar that we've got on the 18th that's coming up, that's been done by First Class. We've got another 5 webinars that have just been announced, and these will all be public facing ones with Q&A sessions, and they'll all be about the vaccine as well. And so on the panel there, we'll have Councillor Hamilton, the local representatives, as well as the Solihull and Birmingham CCG. And the links to those events will be coming up in tomorrow's email as well. So in other news, we've got the lateral flow sites. Hopefully you'll have noticed by now that there are a great number of these across the city that are being launched regularly. I think the latest ones have been at Maypole, the Arcadian Centre and Castlevale Stadium. I think these ones close on Sunday at 8 o'clock, so this Sunday. So that's something that you might want to share with your communities if you're from that actual area. After that, we've got another couple that are going to be opening on the 1st of February, and they are at Sheldon Community Centre, Sheldon Heath Community Centre and King's Standing Wellbeing Centre. And so we'll be sending out the details to those this week as well, or perhaps next week. Something else that you might have seen in the emails is our Champions Survey. So I think that launched at the start of, or the middle of the month, I think. But that'll be closing on the 31st, so the end of this month. So if you haven't had a chance to fill that out yet, either have a look in your previous emails, or we'll be sending out an update on that this week as well. And so getting straight to tonight's webinar then. So we'll be joined, as we were in the last one, by Dr. Dino Motti. He's Public Health Registrar for Birmingham, and he'll be taking us through all things to do with the vaccine. As ever, you'll be able to ask your questions in the chat box, but I think because there's quite a lot of detail to get through, I think we're going to have a designated sort of pause in the presentation where we'll be able to sort of collate whatever's in the chat box, and then we can ask that of Dino and he can give his answers that way rather than it sort of getting all clogged up. And yeah, so with that in mind, can we make sure that all microphones and cameras are switched off, please, and that any questions that are put into the chat box are brief, because obviously you need to sort of help us out in trying to collate all of this information so that we can get your answers as succinctly as possible. And so yeah, if there are any questions in the chat box that need answering as well, can we make sure that it's just the host that answers those, because we need to make sure that everything has been properly answered and correctly. And yeah, so after Dino's finished his presentation, we'll have a short update from Rizwan at the CCG, and he'll be giving the story from their side of things, and also capping off by fielding any other questions that might have popped up in the meantime. But apart from that, I think that's a whirlwind tour of everything that's happened this week. Hopefully I haven't missed anything. I'm sure Holly will let me know if I have. But otherwise, I'll pass over to you, Dino, if you're ready.
Thank you. Yes, Jack. And thank you, Rizwan, for attending today. Obviously, whenever a question is posed that you can answer better than me, you're very welcome to jump in and help me out. Thank you. I'll share my screen and we can, without further ado, move on to the presentation. Let me see if it works. Is it full screen? Can you all see it?
Yep.
Excellent. So let me just collapse the presentation here on the side. Good. This is the second part of what is supposed to be a three-part presentation, which will, as primed, is meant to prime COVID champions on a series of topics. So in the last episode, we covered testing and we did a primer on immunity and vaccines. And we'll pick up from there. I just do a quick recap on what we discussed last time, which is the topic of adaptive immunity. Adaptive immunity is what the body does after the barriers of our body have been breached, the skin, the mucosa, the mucus, and then the automatic defenses have acted. There is a little bit of time in which the body builds up an immunity which is long-lasting and specific. That is the adaptive immunity, is what the body does, recognizing the specific enemy that's attacked our defenses and mounting an elite response to that enemy, which is very specific and very effective, but it takes a little bit of time to produce. Just to recap on vaccines, vaccines gain us time. So they give us a notice period, some sort of alert before a real invasion is coming. They expose the body and present and identicate some pictures of characteristics of the invader, and so that the body next time is well prepared with its elite troops to immediately attack that specific pathogen that otherwise would take too much time to fight with non-prepared responses. So our antibodies are part of the adaptive response that attacks. In this case, you will see I picture a flu pathogen, a flu virus, and a COVID virus. The vaccine presents parts of that to the system, to the body, so that the body can build those antibodies so they are ready for a real invasion. Vaccines are something that are really not new. I mean, there are historical elements and proof that show that the Chinese have been doing this since 200 years before Christ, in the sense that they discovered early that by injecting a little bit of the smallpox in a person, you would have a more mild infection, which will then would have given them immunity. Jenner discovered that by passing instead a little bit, injecting a little bit of what the variant of cows was of this virus, you would immunize or vaccinate people, and therefore they would gain immunity. And that's where the word vaccine comes from. Vaccine, from the Latin vacca, which means cow, is fundamentally what a friend of Jenner's called this approach to give immunity to people. And through this early vaccination, we have gotten rid of smallpox for good, which doesn't circulate anymore and doesn't kill as many people at all, given that it doesn't exist, but it doesn't have that enormous impact on human population. The process of development of a vaccine is in stages. It's quite regulated, very regulated. We do have a beginning of basic science where in small scale studies, one studies the actual molecule, the pharmaceutical quality of the vaccine. Then we check them in vitro. We see whether they work against the pathogen. We do some studies to see whether they bind, whether they produce that sort of response from known antibodies. We check them on animals, and then we move on to clinical trials at different stages with different numbers of people to see whether they are effective, what the efficient dose is, and whether they do provide protection. Through all of these stages, there are a range of institutions that are there to scrutinize the process. And at that point, traditionally, we scale up production and we continue observing the efficacy and safety of vaccines. With, just to recap, the phase 1 of a vaccine trial checks whether it's safe, generally speaking. In phase 2, we check whether it works and what is the right dose. And in phase 3, and you see in these circles, I show you the number of people involved in these trials. With a larger number of trials, we check actually the effectiveness of the vaccine. And then we keep monitoring its effectiveness throughout for several years to see how it works, whether there are any changes or there are very, very rare events that we have to be aware of. In a trial, we can observe a lot of endpoints, usually, and for this vaccine, we've looked mainly whether it prevents disease and severe disease in particular. What has made this vaccine faster? I just described a very complex series of steps, which usually require several years. In this case, we're being fast. Why? First of all, because red tape was cut, but that means that the regulators kept asking for the data throughout. It was a rolling review. The same standards were followed, but this vaccine, given the emergency that the planet is experiencing, was given always priority. So there was absolutely nobody in front of the queue. The vaccine met no traffic in its let's say, course of review by regulators. Another factor that made it fast is that these new vaccine technologies were available, and the vaccine was much easier to produce, and so much easier to produce that actually the pharmaceutical companies started producing it immediately. Just they ran a commercial risk, but they decided to run immediately and produce it immediately, because if it were to be approved and it were to be effective through the very rigorous process, they would already have some doses to provide, and we could start vaccinating. And this is what's happened with this last few vaccines that we've seen in the UK being used. There was obviously an enormous global focus, which drove competition, and a lot of political urgency being expressed by politicians. There was obviously more financing, which increased funding, and we were also sort of lucky in the sense that many of these vaccines had already been researched previously, so we knew that they worked for other very similar pathogens like SARS and MERS. Standard vaccines, as we said, if you notice, it is a step approach. So it takes a little bit more time because every phase is done in sequence, simply because there is usually not an enormous urgency and there are a lot of other drugs to be reviewed, and the system cannot cope with everything coming at the same time. So there is a little bit of a bureaucratic delay in approval, and the funding is not there to do an enormous trial in a rapid fashion. And also because there is no pandemic, so there are not many people that you can check the efficacy of the virus, of the vaccine against, because there is no pandemic. So there are not many numbers of people that you can check whether they develop the disease or not. With COVID, a lot of these things were done exactly in the same way, but in parallel, because there was an urgency and there was a lot of funding, and there was the number of participants in the trials required given the pandemic stage of this disease. And as you notice, the authorization was done in parallel. So all the data that was produced was reviewed weekly, regularly, even daily, I would imagine, when data was available. And this allowed the vaccine to be available earlier and authorized earlier. But the exactly same process was followed throughout. This is what a rolling review cycle means. A standard review means that we wait until the data is being produced, and then this is data. This is an infographic from the European Medicines Agency, which is the European regulator, but all regulators operate in the same way from this respect. At a certain point, the EMA, the European Medical Regulation, would have started looking at the data. In this case, they were asking for the data throughout, so they could start forming an opinion, a regulatory opinion before, and so the actual review took much shorter. And that was why we had the vaccine early and authorized earlier. That said, there are still a ton of vaccines that are going through this process, so the process is not stopped. Just some vaccines were approved, and some others are still waiting for the data to be looked at. The further stage that after all of these reviews is always happening for all medications is the ongoing vigilance for what they're called ultra rare events. Even when we recruit thousands of participants in stage 3 trials, we cannot assume that something that happens once in a million, once in 10 million cases will have popped up. That's why for years we keep looking at the vaccine's behavior, the vaccine safety, the vaccine efficacy, so that if anything has to be reported back and any changes to be made, that is something that is continuously studied. And these things are still going on. These studies are going on as we speak. It's what's called a phase 4 extended clinical trial. I would stop here. If you have any questions very briefly, then we can move on to the next stage of the presentation.
I don't know, I've been recording them as we go, so I'll just ask them quickly now, if you prefer. Okay, so the first one is from Stephen Booth, and he says, a colleague was vaccinated yesterday and was informed that 40% of COVID vaccine is wasted due to no-shows. He wants to know if this is correct and what steps are being taken to offer this to people who will show up.
That is a very interesting question. And I was going to highlight that aspect later when I speak about the specific vaccines, some of the strengths and weaknesses. But I can tell you, first of all, unfortunately, I don't have that data, so I cannot confirm whether 40% or not is an accurate figure. What is known is that, especially with the Pfizer and Moderna vaccine, once these are thawed, once these are taken out of the deep freeze in which they're held, they need to be used. And therefore, sorry, somebody is calling me in this specific moment. So I'm gonna, because
sorry, Dino. Maybe I can come in on this one because
yes, please.
I have the working experience of having run a vaccination center in my PCN. Yeah. No, it's not true that 40% of the vaccines are going to waste, because we always have a reserve list of people who are still within the priority groups. With the AstraZeneca vaccinations which are coming through to general practice and to the pharmacy sites, those we can even store, because you only take the one vial out, which either has 8 doses or 10 doses. So those, once they're stored within the fridge, you can use them within any time. So there is no wastage there at all. For the Pfizer, it's a bit of a different question, because once it's thawed, you've got 6 hours to use it. And within that time, believe me, there are a lot of people who want the vaccination. And even within the priority groups, if we're working at the over 80s and we had exhausted those, then we would go over 75s. And we all need to do is send one text message out, and we would be inundated with the number of people who want the vaccination. So in our experience at the practice and at the mosque, where I'm a trustee as well, where vaccinations have been taking place, there have been nothing going to waste. Every dose is being accounted for. In fact, in some of the vials, you can get an extra dose, and those are under the watchful eye of a clinician. And we are actually then generating almost 190 extra doses to give out at the same time as well.
Thank you, Rizvan. Exactly. That's exactly what I was going to say. The system has a way to call people when available doses are not taken up. And again, there's been an effort to make sure that every single drop of the vaccine is being used. I'll share against my screen.
We've just got a couple more questions, you know, if you want
yes.
to take those, but maybe if there's something that's particularly detailed or something, perhaps we could get back to it, but if you just want to address the crux of the point. So we've got one from Sunita here, who asks if there's any chance of trying home visits to immunise those who can't easily attend, such as the elderly or vulnerable.
Okay, more technical question. I can answer that, because again, with the experience on the ground, yes, the Birmingham's BCHC, which is the Community Healthcare Trust, is already working with all the GP surgeries to immunize those who are housebound. One of the curious things was that patients who have been semi-housebound have actually found ways of coming into practice, because it's quicker for them to come in. So families have been quite proactive in making sure that they bring grandma or granddad into the practice, because they don't want to wait for the vaccine till we get around to going to their homes. So we're very, very thankful for family members having taken that responsibility and taken that step to bring them in. So I think there is a balance in that a number of housebound patients are actually coming in, but also we are going out to them as well. I can reassure you most of the care homes have now been covered as well, because we've had rolling rotas for clinicians to go out and vaccinate them.
Okay, great, thank you. We just have another couple here that sort of overlap slightly. So Alison's asking whether, sorry, so a lot of younger people working in social care are worried that the vaccine affects fertility and wants to know whether that's true or not. And the other one that overlaps is in reference to something that the CDC in America has perhaps stated, that vaccines should not be used in pregnancy, and whether that's the case for UK vaccines. So I'll leave that one to you two as well.
I will cover the question on pregnancy in the second part of the presentation. And with regards to fertility, there is absolutely no evidence that the vaccine affects fertility. And I would cover those in probably the third part of this series, where we look at exactly what all the misconceptions about the virus and have been. But Rizwan can back me on this. There is absolutely no evidence mechanism for fertility to be affected by a vaccine.
I mean, all the evidence at the moment, which is being made available to us from the manufacturers, suggesting that there is no effect on fertility whatsoever. I mean, at the end of the day, if you think about it on a more teleological point of view, it's a spike protein that we're injecting in the mRNA. It doesn't even have an active virus as such. So the medical sort of interaction or molecular interaction within the body is very, very minimum, apart from inducing an antibody response to a foreign protein. So it doesn't have any hormonal issues or any sort of any other sort of response which would therefore affect fertility in any way.
Okay, and in terms of pregnancy, then is anybody advised to not take the vaccine? Or
I'll cover that later, but at the moment there is again no evidence that the vaccine is dangerous in pregnancy, but there is a limited amount of evidence. Therefore, at the moment, is not offered routinely, but it can be used in pregnancy.
Okay, great. And just
I'll
as
cover that in a later slide.
Brilliant. Okay, and just in terms of the managing of the webinar, could everyone make sure that their cameras are turned off, please? And also that we keep our questions as brief as possible. For obviously we're short of time as it is already. So yeah, make sure that your questions are to the point and succinct. Okay, thank you. Back to you, Dino.
To the presentation. Okay. I would like to cover a little bit what the different vaccine types out there are and how they work. There are, I would say, globally speaking, three main approaches to making a vaccine. You can use a whole virus, whole organism. You can use parts of that organism, or you can use just the genetic material of that organism to produce the parts that then will trigger the immune system response. The whole virus approach can be using an inactivated vaccine, which is fundamentally a dead vaccine, a vaccine that's been modified to not produce disease, but still be recognized as a virus by the organism, or a vaccine which looks like a virus but contains the DNA of another virus, which fundamentally is a virus which delivers that DNA, that RNA, that genetic material to the body. One of the vaccines what we're using is of this kind, the Oxford vaccine. There are more, let's say, scientifically advanced approaches that look either using subunits, but specifically they use just the RNA, just the genetic information, and the Moderna and the Pfizer virus vaccines are of this kind. They encase
Hello, Dino, we might have lost you. Rizwan, can you still see? Are you? Yeah,
Yeah.
you're not frozen. It's just Dino, I think.
Yeah, I'm okay.
Yeah. Okay. We'll give him a minute to come back. I'm not sure if he's aware that he's frozen. I'll give him a quick message here.
Jack, do we want to pick up some of the questions while we're waiting for Dino?
Yeah, I suppose we can. That's
Yeah.
probably a good idea. Yeah. Okay. So we have one that asks whether it's true that none of the phase 3 trials will be complete until 2023. I'm not quite sure what that's in reference to.
Sure. Yeah, I'm not quite sure about those. I mean, we've had reassurances from all the manufacturers that they've done phase 3 trials, and the data, MHRA wouldn't be approving data without having those sort of figures, to be fair.
Yeah.
So I'm not quite sure about that.
Okay, that's fine. So the next one we have from Fiona, who asks, how long will it be before there is enough evidence to know if being vaccinated prevents people from transmitting COVID?
Sorry, I had a glitch with the connection.
Yeah, we were just filling in some time while you were getting back, Dina.
I'm back. I hope that, just a second. Can you see now the screen?
Yes, thank you.
Is this where I dropped off, or should I go back one slide?
I think you dropped off on the on a previous slide with the viruses you're talking about.
This one?
That's the one. That's it.
Okay, so I was saying that the whole virus approach can either use a killed vaccine, inactivated, which means that the vaccine has literally been destroyed, but is still recognized by the immune system, it is not live. A vaccine which is live, but is being modified not to produce disease, or a vaccine which uses a virus, which is just a shell in which another genetic material has been inserted. And the Oxford vaccine works a little bit like that. It's a chimpanzee virus, which though includes the DNA or the RNA, in this case, the genetic material of COVID, to deliver it to the cell for the immune system to work on it. Other approaches use subparts of the virus, and the Pfizer and Moderna, the mRNA viruses, are of the kind shown here on the right, which use just the RNA with no virus at all, and encase it in some lipidic material, which is fat, a droplet of fat fundamentally, which is then readily absorbed by the cells and does exactly the same job as the Oxford vaccine, but is very, very delicate, needs to be kept at low temperature, and is destroyed very rapidly if not taken up by the cells, doesn't travel around in the body at all. The available vaccines, as I mentioned, are 3 at the moment. There are 2 of a similar kind, which are Pfizer and Moderna, shown here on the left in yellow, and the ones using the viral vector, which are the AstraZeneca ones, which is the Oxford vaccine, also known as. And there are more vaccines in the works. You probably heard today the news there is another vaccine that will be produced in Scotland, but at the moment they're not among the ones being used. As I said, there are 2 broad types of vaccine currently used for COVID vaccination, which are mRNA vaccine and viral vector or attenuated virus vaccines, which are the mRNA here shown in yellow, the viral vector in blue, Pfizer, Moderna, and Oxford vaccine. They all do exactly the same thing. They aim to show the immune system that spike that is used by the virus to attack the body, to enter the cells. They train our immune system to recognize that spike so that when an actual COVID virus attacks us, enters the body, our immune system is trained to recognize that. They use 2 different avenues to do so, but they're very, very similar. The viral vector vaccines fundamentally include the RNA within a virus that we know very well, which is being gutted and emptied, but is very effective at delivering this RNA to cells. Once the RNA is in a cell, this is fundamentally the plan, the construction plan, the instructions to produce
Has it happened again? All right, sorry about this, everyone. I think it looks like Dino's having a bit of internet trouble. We can fill the time again with some questions if you like, Rizwan.
So where were we?
Right, so where were we? So the last one was, how long will it be before there's enough evidence to show that vaccination prevents people from transmitting COVID?
So this is a bit of a tricky question in the sense that the endpoint for the studies for the viruses, for the vaccinations, was actually getting a COVID infection. And therefore, that was what was looked at essentially in the first place. Now, the premise being that if you don't have a COVID infection, you're not going to transmit it. So that's the basis of what the trials have been so far, as I'm aware. There will obviously be ongoing studies regarding transmission otherwise, and hence that's why we ask for social distancing as part of the normal lifestyle choices, even though you have been vaccinated with your first dose.
Okay, brilliant. Thanks, Rizwan.
I am,
if you're back, Dino.
I'm really sorry. My internet is playing up. It's never done it before, especially in the evening like this. But so I can only apologize. I hope it doesn't happen again. I'll go back to the presentation if I manage. And thank you, Rizwan, for picking up the slack.
You're welcome.
I really appreciate it. I was explaining, if I got cut off here, viral vector vaccines use a virus that we know well, which doesn't cause disease, which is emptied and is just used as a deliverer of the RNA that codes for the spike protein, which is that element of COVID that we want the immune system to learn to recognize. That RNA is brought into the cell, not in the nucleus, doesn't get in touch with our DNA at all, is just immediately translated into the protein that is then exposed outside the cell and trains our immune system to produce antibodies and be ready for an actual attack. This is how the RNA is inside the virus, which has been engineered to contain it. It's brought into the cell and allows the cell to produce the spike outside of itself, which then is recognized by the immune system. It's non-replicating, it gets destroyed very quickly, but the cells use that RNA to expose the spike protein outside of their surface so that our immune system can see it and is prepared. That's how it works. It's got the advantage that, as we know, viruses are pretty resilient beasts, and therefore this vaccine can be conserved at normal fridge temperature, and even outside the fridge it survives for quite a while. The mRNA vaccines are fundamentally doing away with the virus at all. They just use the mRNA, just the sequence, just the instructions, and they put it in a blob of a lipidic blob, which is fat or oil fundamentally. It's a little droplet of fat, which then is absorbed by the cells without the need for a virus. This has an advantage. It's very easy to produce because obviously we don't have to have this virus and engineer it. We just produce the sequence of RNA, which is much cheaper to produce, but it also got the drawback of being very delicate. That's why you probably will have heard that this, especially the Pfizer, this vaccine has to be kept at -70 and needs to be used immediately after it's been thawed. That means that rather than being wasted, we would be offered to someone else if a person cannot take it up. But as Rizwan has highlighted, we do have systems in place to make sure that all the doses are assigned and used efficiently. And this is how it works. Just DNA in a little lipidic droplet goes into the cell, and the cell produces the spike, which then trains antibodies which are specific to the spike protein of the COVID virus. It's very delicate, doesn't travel anywhere in the body, doesn't get into the nucleus, it's destroyed if not absorbed by the cell, very, very quickly. That's, again, the reason why we have to preserve it at such low temperatures. This is just to repeat what I said in the other, reinforce the message of what I said in the other presentation. Why do we vaccinate? At this stage, we vaccinate to prevent severe disease and death. And this is because we're at the beginning of the vaccination campaign. We don't have lots of vaccine. We target specifically those that are most vulnerable. And we also do that to hopefully prevent spread. So we will have more vaccine and we'll vaccinate everybody to achieve herd immunity. There is at the moment mounting evidence that there will also be some ability of the vaccine to prevent spread, but at the moment that evidence is not yet fully available and robust. So at the moment, we do not advise anybody to change their behavior after the vaccine. You continue to behave exactly like you did before, hands, face, and space. And because at the moment, the main goal of the vaccine is to reduce mortality and hospitalization. We're vaccinating those that are most at risk and which are therefore prioritized for vaccination. This is just to highlight what herd immunity is. As we said last time, we also hope to achieve a sort of firewall that will prevent the spread of the virus in the coming months and years. The vaccine is given as an injection in your upper arm in 2 doses, which are spaced 3 to 12 weeks after the first dose. You will receive a letter, which will allow you to book your vaccination appointments online, and the instructions are inside of that package. Why 2 doses? It's very common practice to many vaccines, like MMR, for example, and it is done to improve the effectiveness. In some cases, like the flu, as I said last time, we even give the vaccine every year because the virus changes. The vaccine, is it effective? The first dose of vaccine should give you already good protection from coronavirus, but you will need to have the second dose of the vaccine to give you the protection that the research has shown that the vaccine can give. So there is a chance that you will still, as I said before, spread the coronavirus even if you had the vaccine, and you may need a booster vaccination in the future. Who can get the COVID-19 vaccine? At the moment, it has been offered throughout the system. It's expanding its provision. It's being given to all the people who live and work in care homes and health and social care workers high risk. And this is just being widened and widened as these groups are reached by the vaccination. This order and this prioritization is decided by the JCVI, and local authorities do not have a role in deciding the prioritization and allocation of vaccine doses. I can pause here for some questions, or I can move on to the FAQ that I have at the end, and we can take the questions all together. I don't know what you think, Jack.
I think maybe take a couple because they've built up quite a bit.
Okay.
If we can get through, say, half of what we've got already. Yeah, so I'll try and be as quick as possible then. So we've got one here that references VAERS data, vaccine adverse event data, which is something that the US collects. This person's saying that there are 180 plus deaths so far following the Pfizer vaccine, and would like a comment on that. I'm not sure how disposed you are to give a comment on that, but yeah, if you do.
I haven't personally seen this data.
No.
Vaccines, I haven't read this data or known of these statistics. Obviously, the denominator is a completely different element that we have to consider here. But vaccines, especially in hours after the vaccination, don't protect you from COVID. They take a while to act, and a person can still die of another cause after a vaccination. So I would like to see this data. At the moment, I am not aware of any serious consequences that are considered due to the vaccine. But Rizwan can back me on this. I haven't seen data that shows.
I haven't seen much data for this. I mean, to be fair, I think the reporting was fairly robust as far as adverse effects were concerned, and we knew within the first day of the rollout with the Pfizer vaccine regarding the hypersensitivity reactions, and hence we took adjustments in whom we could give it and whom we couldn't give it. And I hope that demonstrates the robustness in the system, where we're looking at the safety of the vaccination as we're giving it as well.
Okay, great, thank you. We have another one from Debbie Hemsley, who says that she's a carer and works as a carer. One person has told her that she should be a priority for the vaccination, but she's not sure how her GP or the NHS would be aware of this. She said she spoke to her GP and was told that she would have to wait until contacted because her age band is that she's in the 50 group.
Well, that's correct, because
Yeah.
the carers we were looking at were social care carers in care homes who were the priority groups, because obviously in care homes we know that the virus can spread quite rapidly, and therefore it was them who were classed as carers and hence given the vaccination as a priority.
Okay, great. We've got another one from Susan, who says that the number of first doses being given is going up rapidly, but in around 10 weeks we will have to start again with the second doses for the same patients. And she wonders how this will affect the continued rollout of first doses, if at all.
I think the first thing is, obviously we're all dependent on the supply of the vaccine. So far we haven't had many issues with the supply of the vaccine, and we have been reassured, despite all the news articles we've read about the EU and Pfizer vaccine, etc., that there is adequate supply already available. I think the second dose will carry on concurrently with the first dose. I think we're learning with our experience as we're going along. So I think at the end of the day, the simple process is giving a vaccination, essentially. As long as there is supply, we can keep jabbing, and our recall systems are fairly robust, because we are now, well, we have been from the onset putting data onto a national recall system. So everybody who has had the vaccine will get a recall within the given time.
Okay, great. Just two more short ones then. The first is, what are people who have had the vaccine being told in the way of still needing to social distance? So do you still need to social distance if you've had the vaccine? And the second one asks more directly whether the slides that are currently in use will be shared. So that's one for you, Dino, specifically.
The slides can be shared as a PDF and on request.
Yeah.
In terms of the advice, yes, you will continue to have to socially isolate and respect exactly the same rules that are applying to everyone else. And I explained the reason is that you might still be spreading the virus, and there are other people that are not vaccinated. So we want you to be applying the same infection control guidelines as everyone else.
And to be fair, just to add to that, it doesn't mean that the vaccine isn't effective. You get most of your immunity from your first dose. However, it takes a certain amount of time for the immunity to build up. You're not going to be immunized as soon as you get the vaccine. It takes up to 3 weeks for the immunity to build up. So therefore, the social distancing rule doesn't change until you've been fully vaccinated.
Yeah, brilliant. Okay, and yeah, just to add as well, Dino has an FAQ section within his PowerPoint as well, so he'll hopefully clean a few of these up before they need to be asked as well. So we'll get moving towards that.
Okay, I'll share the screen again then. Can you see it?
Yes.
Perfect. So I'll move on to exactly that question. I will skip it very quickly, but it is important you continue to follow social distancing guidance and other infection control precautions, because you may still spread the virus, because the vaccine takes a while to act, as Rizwan has said. Frequently avoid touching your face. This is one of the questions that I heard the most mentioned in the last months. Does the vaccine change my DNA? The simple answer is no, because it simply cannot. It cannot do that. The RNA doesn't go into the nucleus where the DNA is held. There are two different molecules. The RNA stays outside of the nucleus in the cell, is only read and is not transferred anywhere else. It's only used as the blueprint to produce the spike protein that we discussed, which then is used by the immune system to mount and prepare a response for a proper infection by COVID.
Dino,
Another question.
Sorry, Dino. It may be worth just adding on this point about the DNA change, that the DNA is a blueprint and it is always in the nucleus, not anywhere else in the cell.
Exactly.
And because the mRNA is going nowhere near the nucleus, there is no chance whatsoever that it'll change your DNA at all.
Absolutely, exactly. The mRNA is called messenger RNA, is a transcription from the information held in the nucleus in DNA. And that transcription goes only one way, goes outside of the nucleus, never comes back. So whenever RNA is involved, that RNA does not enter the nucleus. It is kept separate from the information of the DNA. So there's no chance physically. How effective? This is another question. After the second dose, Pfizer and Moderna are around 95% effective. And after the second dose, the data shows around 70% effectiveness, with a range, depending on the regime, between 62 and 90% effectiveness for the Oxford vaccine. This is the short answer. Serious allergic reactions. This is another question that I heard. Like all medications, if you have had a serious allergic reaction, you should tell healthcare staff, and you should not have the vaccine if you've ever had a serious allergic reaction to some medicines, household products or cosmetics, a previous vaccine, or a previous dose of the same COVID-19 vaccine. And this is the question about pregnancy that was asked before. There is no evidence that the COVID-19 vaccine is safe if you're pregnant, but more evidence is needed before it is routinely offered in pregnancy. The JCVI has recently updated its advice, and he recommends that you may be able to have the vaccine if you're pregnant and you're at high risk of developing coronavirus because of your work, or have a health condition that means you're at high risk of serious complications from coronavirus infection. So you can also have the COVID-19 vaccine if you're breastfeeding. You do not need to avoid pregnancy after vaccination. And the vaccine cannot give you or your baby COVID-19 in any way or form. Another question that I heard, and this I believe is my last slide on the FAQ. Does the vaccine contain porcine ingredients? All of the 3 manufacturers of the COVID-19 used in the UK do not use pork as part of the vaccine. And the British Islamic Medical Association has stated that the Pfizer vaccine is halal. And with this, I have concluded this second episode of the primer on testing, immunity, and vaccination, and I'm still available for questions.
Okay, great. I'll keep going through those then. I'm not sure if we'll have time for all of them, because obviously there's quite a lot in that chat box, and they're rather detailed as well. So if there's any that we don't get to, we'll answer those over email. So we've got one from Carol, who asks if there is any evidence of acquiring COVID-19 after Pfizer or Oxford vaccine, such that it results in hospital admission. I think you've already answered that one, haven't you? So Reg asks us, what can you tell us about the efficacy of each of the 3 vaccines from the first jab and the immunity being gained from having had the virus? And you'll have to forgive me if these are things that you've already answered, because it's quite difficult to keep track of it all.
Rizwan will back me on this. He might have seen more detailed data. The efficacy of the virus is studied for 2 jabs. At the moment, there are studies that show that the first jab gives you a pretty good level of vaccination, and that's why the priority has been of giving the first jab to the widest number of people possible, rather than waiting to give a smaller number of people jabs. That said, the studies that show the 95% efficacy are based on 2 jabs, and that is where the goal is, to give both doses of the vaccination.
Okay, great. Yeah, so we've got another one from Andy here, who asks, so in May he's looking forward to, will it be safe for him to go into a large indoor event amongst other people who may not have received the vaccine? The event specifically is election counts, which he says that the government will the government says will currently go ahead?
It's a difficult one, to be fair. Yeah, it's a difficult one because we can't obviously tell who else is vaccinated in that room and etc. etc. So it's a little bit of a unknown quantity, if you may know. I mean, you may be protected after your second jab for up to 95% efficacy, but other people may not have received their second jab. So it's a bit difficult to say.
Right, great. Okay, another one that you may well have answered as well. So Carol asks, what level of herd immunity through vaccination is thought to be needed in society and globally? Another quite broad one that might be difficult to answer.
Is that in order to achieve herd immunity, I believe?
Yes.
Yeah.
I haven't seen a definite answer to that threshold. I believe the last time I looked, it was above 70–80% of the population, but there might be some more recent study that has looked at that percentage.
I mean, to be fair though, there is a point to be made here that if we're not going to get enough people taking on the vaccine, then we're not going to achieve the herd immunity essentially. And this is why I myself and a few of my other colleagues within the BAME community are actively supporting and actively encouraging our populations to take on the vaccines, because if not yourself, it also protects others as well. So, you know, the wider gain for society is the herd immunity if an adequate number of us take the vaccine as well.
Okay.
Absolutely. I mean, herd immunity as a whole depends also on the community. So if you are in a community where the majority of people are not being vaccinated, the spread can still happen, and we've seen it in the past with measles. It's very important not to become, let's say, complacent with vaccination. It can easily be a false economy, that of saying we've reached the herd immunity, therefore I don't vaccinate. That's not the approach that we should use. There are people that cannot vaccinate, and that's the population that we are protecting. There are people with an immune system that doesn't allow them to vaccinate, people with cancer or other conditions that prevent them from having a vaccine. The most vulnerable in society are those that benefit the most from our own vaccination. So it's an outward sign of a society taking care of the most vulnerable.
Okay, thank you. We've got another one from Fiona. Her question is Birmingham specific, and she asks how the city is doing with the vaccinations. And she would like to know what groups have been vaccinated and how long will it be until we get to group 5?
Okay, so I think I can give you a perspective from a GP surgery in a PCN. Essentially, we have already vaccinated the majority of over 80s, and now are also past the over 75 mark and going towards the over 70 marks. And obviously, we have included those in the health and social care sectors within this as well. So we're doing okay. I think we're doing substantially well in the Midlands. I think from the 14th of December, 14th of January rather, we were in the lead nationally. But I don't think we've gone that far down further. We would still be within the first top 5 at least, I would have thought. I haven't seen the data recently, but yeah, we seem to be doing quite well.
Okay, great. We've got another one from Alison, who asks if there is any help for people with learning disabilities who might be needle phobic.
I think, again, each case is taken on its merit. These are very specific sort of group of people who are not the easiest to vaccinate, but with the help of the carers and people they're familiar with, and because a lot of them may be in care homes, it is quite a lot more easier when there is some assistance from somebody they're familiar with.
Okay, great. We've got one from Jane here who is referencing Susan's comment and asks if written down post-vaccination info is given to people, or whether it's just verbal. So whether once they've had the vaccination, they're just given their instructions, or whether they're given something that's written down. I'm not sure if you're aware of that.
Sorry, can you please repeat the question? I just
I'm sort of slightly interpreting it myself a little bit, but I hope I've got it right. I think it's asking whether once somebody's had the vaccination, whether they're just given their instructions as to what to do next by the person administering it, or whether they are given some sort of literature or pamphlet or something like that to know what to do.
There is always a patient information leaflet which goes with every vaccination. In terms of the recall for the second jab, it is something that we are waiting further instructions from NHS England and the authorities. But I believe most providers are booking provisional dates with patients up to 12 weeks from the first jab.
Okay, brilliant. I think we're coming to the final question. I will run through these later on to see if there are any outstanding, and I'll get back to those people through email. But otherwise, I think this is the final one, which is from Steve, who's saying that having listened to the news today about Germany not recommending the Oxford vaccine for over 65s, and he wonders if there is a risk for us or if we are okay.
I have read those news myself, and they were talking about some outlandish, personally, numbers. I think they misunderstood some numbers when some politicians mentioned the Oxford vaccine. I think they referred to an 8% efficacy, which is that the composition of that age group in the trial. So they misunderstood that element, and the media has amplified a message that is not correct. So that's unfortunate, but that's what happened.
Right. Okay. Yeah. Yeah. Well, I think in that case, then that's it for the questions. I'd like to congratulate myself for making it to bang on 6 o'clock, so we can all have our dinners. But yeah, apart from that, I think we've got some updates coming up soon. Obviously, as I mentioned, the survey, etc., things like that. So if all the champions want to keep their eyes out for that, that'll be coming this week and next. But apart from that, yeah, thank you, Dino, and thank you, Rizwan. And we'll see you all soon. Thank you very much.
Pleasure.
Thank you, everyone.
Okay, good night all. Bye-bye.
See you.
Good evening, everyone.